Hey everyone, Oscar Ortiz with the SebastianStrong Foundation, here filming our second SebastianStrong Spotlight on Community Superheroes. Got a special guest with us today. I'm going to introduce shortly, but when we think about community, because this is a community-focused show, it's very often people think geography, where we're located. However, community is much more broad than that. And today I have someone who's part of the childhood cancer community. And, you've heard from me, whether it's through a show, our original show, or if you follow us on social media, the perspective of a parent and what the childhood cancer journey is like. But there are various stakeholders in the childhood cancer world, from patients, obviously, to the pharmaceutical company, to the government that funds research. But one of the key stakeholders that we don't hear often enough from are the medical side, the doctors and the nurses, and their roles in this world and the important role that they play. So today I've got a good friend, a great doctor, and even greater human being here with us, Dr. David Loeb, who is chief of Pediatric Oncology at Montefiore in hospital in the Bronx. It's the second largest hospital system in New York. Also a researcher at Albert Einstein School of Medicine, a wonderful human being, and grateful to have him here on the show. So David, thank you for joining us today, or joining me, and for all the important work you do.
Well, thank you for having me.
We'll go ahead and get started. Again, this is a casual, an intimate conversation, and the goal here is really to educate the public a little bit more of, like I said, the perspective of a doctor in the childhood cancer journey. So, David, how did you come to be a pediatric oncologist? What was the journey? How did you decide? Because it's a really tough job.
Well, it's a long story. When I was in high school, I knew I wanted to do cancer research. And I went to college and studied biology, and I worked in a cancer research lab. And I was actually my father who told me that there were these programs after college where you could simultaneously earn an MD so you could take care of patients, and a PhD so you could do research, and suggested that I look into them. And I had never really thought about being a doctor. I'd only thought about doing research. And the advice that he gave me, which I thought was really great, was if you really want your research to have an impact, you need to understand the medicine so you know what the important questions are, so you can focus your efforts where it will have the most impact. And that seemed like good advice to me. So so that's how I ended up in an MD PhD program
At Columbia, correct?
at Columbia. I thought for a while about exploring different areas besides oncology, and so I actually did my PhD research in a neuroscience lab because I thought it would be really cool to understand how the brain works. We still don't understand how the brain works.
I think we're still working on that.
Still working on that. But I found myself gravitating towards research projects that actually ended up being more aligned with cancer than with neuroscience. After the way the program is structured, you do 2 years of medical school classes, and then go to graduate school, and then do 2 years of clinical training afterwards to sort of finish up the MD part. When I went back to the clinical part of medical school, I had thought that maybe I would be a neurologist in line with having done a PhD in a neuroscience.
These are all
lab.
the rotations where you when you're going through medical school, you get exposed to various parts of
exactly. And my exposure to neurology told me that, at least back then, neurologists were great at diagnosing problems, but they didn't have any tools to fix those problems. And that wasn't really appealing to me. So then I went back to my original idea of taking care of patients with cancer, but I had envisioned it being adults because when I was a kid, I was blessed to have really good health. And so my vision of what a pediatrician does is primary care pediatrics, just health maintenance as kids were growing up. And that didn't really appeal to me either. But when I did my pediatrics rotation, I realized that actually kids get sick with the same sorts of things that adults do. But what I also learned was that kids are still kids, even no matter how sick they are. And it's fun to work with kids, and it's not fun to work with adults. Adults complain a lot. Kids typically don't, at least not in the hospital setting. And I found myself drawn more towards taking care of kids with cancer than taking care of adults with cancer. And so I ended up going to do a pediatrics residency and a Hem/Onc fellowship, and here I am.
Oh, it's an incredibly noble profession because it's really hard work, and I do agree with you. There's so much that can be learned from watching kids go through this. They do it with such grace and nobility. As adults, we're not so much. Not so much. You mentioned obviously the clinician being a clinician who, and for the audience, clinicians are those people who take care of the patients and researchers, because in this world there are people who focus on one or the other. They take care of patients, and then the researchers who do the work. What percentage of people in the pediatric oncology world fall into one camp or the other? The majority?
The vast majority, I think, do either one or the other as their full-time occupation. One of the things that's different about pediatric cancer compared to adult cancer is the role clinical trials play in the care of patients. In the adult world, a clinical trial is sort of a last-ditch effort at the end after everything that's standard has not worked. In pediatric cancer, clinical trials are the standard of care, and as a community, we try to put every child that we take care of on a clinical trial because it's the only way we'll learn and be able to do better. And so the distinction between being a clinician and being a researcher is a little bit of a gray area in our field, because almost every pediatric oncologist works within an academic medical center. There's essentially very little private practice pediatric oncology. And because it's all of the clinical work is done in the context of an academic center, all of us know how clinical trials work hard to enroll kids on clinical trials, and that's research too.
Yep.
And so, but if what you're asking is what percentage of people are really research focused primarily versus clinical primarily, almost everybody falls into one of those two camps, and maybe 10 or 15% of us sort of straddle both.
Okay. Yeah. In the time that I've been in it, it's unique. And I think it's obviously helpful to have that broad perspective because, from my business standpoint, every once in a while you had someone in marketing with a great idea, but that great idea is how you're going to convey that to the customer. Because in a bubble, it sounds great.
Yeah. But
when on the front line, when you're having these extremely challenging conversations with parents, and I wanted to touch on, you mentioned clinical trials, and the reason that is because kids have such limited options. There isn't established in very many cancers, in pediatric cancers, there aren't, we have success in leukemia, like you and I were talking about before the show, but very often there are not long established successful protocols. So that's, that's really hard. That's extremely difficult for the entire community, which leads me to my next question. As a researcher, we've been fortunate to fund a couple of projects with you, which I know one received. I always say we serve as seed capital, or you've secured. I think it was a $250,000 grant. You've secured almost another $500,000 to continue the studies there. And now we're funding another project using, the immune system to fight off. When you look to select projects or stuff that you're interested, what's your process? Because obviously you want success, but it comes incrementally.
Yeah. I don't know that there's a well-defined process. A lot of times the idea for the next project is sparked by an article you read or a presentation that you see, and thinking about whether that's something that might be applicable to the diseases that we take care of. So, for example, one of the projects that we're working on right now involves looking at whether a drug that was just recently approved to treat patients with metastatic neuroblastoma might also help kids with the bone sarcomas that we focus our clinical and research efforts on. And the original idea for that actually came from a mistake that somebody in my lab did. And that's, I think somebody once told me that the best sound to hear coming out of a researcher's mouth is not eureka, it's what? So we started by trying to develop a mouse model that we could use to study how bone tumors spread. And once we had that sort of set up, we started to ask questions using that model to try to understand the specific processes, because if you understand the specific processes, then you can identify ways that you can block those processes, and those you block them with medicines, or and that then becomes a clinical trial, and then hopefully that becomes a relatively standard treatment. So I asked a surgery resident who was working in my lab at the time to look at how cells from the immune system infiltrate into the tumors in our mouse models, comparing tumors that spread with tumors that didn't spread.
Okay.
And I try not to be too micromanagerial when I tell people what experiments to do. So I essentially said, this is the question I want you to answer. Go figure out how to do it.
Right.
And so he went and figured out how to do it. And he found a way that he thought he could look for a specific enzyme in cells in our tumors that he thought would only pick out immune cells.
Okay.
And he compared tumors that spread and tumors that didn't spread, and he saw big differences. And I remember I was on a train from Baltimore to New York when he emailed me these pictures, and I opened them, and they did look very different from each other, which was great. But the marker that he had picked out that he thought was only going to look at immune cells was actually picking out a huge difference in the cancer cells themselves between the tumors that spread and the tumors that didn't. And just coincidentally, it happens that the enzyme that he looked at regulates a pathway that people in our building at Hopkins, which is where I was at the time, were studying in terms of colorectal cancer.
Okay.
So there was a local expert. So I went upstairs to his office and said, this is what we found. What do you think? And he said, I've got a drug you should try. And we started playing with that drug. And the short version of the story is that in our preclinical models, it looks like this drug prevents the tumors from spreading.
Which is, ultimately in cancer, that's you know,
That's
metastatic disease, you know, when it's localized, survival rates are, long-term survival rates are so much better. So it's critically important to, I always say it's whack-a-mole once it gets loose.
yes. And so it looks like this is a drug that can prevent it from getting loose in the first place so that you can maybe avoid playing whack-a-mole in the future. And so we didn't consciously say, let's look at that pathway. We said we have this model where we can compare tumors that spread and tumors that don't spread. Let's try to figure out how they're different from each other. And we had an idea that had to do with the immune system, and it turns out that idea may or may not have been right, but it's what we started looking at, but it's not what we ended looking at.
That's so interesting, because so often people think of medicine as, you know, like black and white science, similar to accounting where I used to work. You know, it's black and white. The reality is there's a lot of art to this in terms of creativity to these approaches, because, you know, and again, I'm not a medical professional, but come to appreciate the complexity of the human body and how unique every person is. Because very often people think of cancer, again, geographic in nature. Like you have lung cancer, that's the same kind of cancer as breast cancer, prostate cancer. And the reality is not only is that not true, but that it is different in each human, that two people diagnosed with the same cancer, same staging, same technical diagnosis, treated with the same protocol can have two very different outcomes. Yeah. I think, and there's a lot more, I think, progress and positivity happening with the realization of that. Because I mean, I've only been in this world for 8 years, and I've seen, you know, where it shifted, where I think for a long time it was the magic bullet medicine, and now harnessing the immune system, because everybody's different, and we all have this innate power, hopefully, to how do we harness that too. So it's incredibly interesting. You know, you've heard me say that research isn't sexy, and I don't very often, and I say that as the executive director of a foundation. You know, last year we committed $1 million to research. We're incredibly proud of that we were able to do that. But at the same time, I recognize that, you know, that would have been $110,000 trips for families. You know, a lot more smiles, a lot more, you know, and there's a place for that. There's wonderful. The Make-A-Wish in the world, they are fantastic. There's a lot of people who do that, but they don't get us any closer to the answer. And it's long, hard work. It doesn't happen overnight. You know, in a world that wants immediate gratification and a silver bullet, you know, how do you define success for a research project? Because I always try to tell our donors, look, you know, this is progress, because we learn from this, and now that gets published, and now we know the analogy I always use is, all right, we got to a fork in the road. We moved forward. We got to the fork in the road. We went left. Now we know that, all right, we shouldn't go left or turn that far left. But that's progress. You know, how do you define success when you go through a research project?
I think you just did. If at the conclusion of the project we know more than we did when we started, that's success. You used the phrase magic bullet, and I remember when I was younger, that was what everybody was always looking for, was the magic bullet, and those are few and far between. And if you look at in childhood cancer, acute lymphoblastic leukemia, which is the most common kind of cancer that children get, when I was very young, ALL was uniformly fatal, and today maybe 90% of kids who are diagnosed with ALL are going to be cured. That progress, that improvement over that time, which is shorter than my lifespan, didn't come as a single magic bullet where somebody discovered the magic drug and now we give it to patients and they're cured. It came about because of slow, steady progress over a long time. And it requires patience. It requires long-term commitment, because you only make incremental progress. But that incremental progress, if you are able to take a step back over time, isn't small anymore. It's really big. And just like a river can carve the Grand Canyon, over time, we're essentially trying to do the same thing.
Yeah. How do you eat an elephant one bite at a time? Yeah. I mean, and which leads me kind of the next question. The resources, because that's one of the biggest challenges I always communicate to people. We are, as a society, we're capable of incredible things when we focus our efforts, and when we have the appropriate resources and adequate resources. Because pediatric cancer is so rare, there aren't the economic incentives from the markets, from pharmaceutical companies to develop drugs. I always use, I think there's been with DFMO, the neuroblastoma drug, I think now there's been 7 drugs that have been developed for kids with cancer, specifically for first use in kids with cancer. While through that same time frame, there's been hundreds of drugs developed for adults. So, the importance of funding, where it comes from. Obviously, the government plays a big role in this, but with it's approximately a $5 billion budget that the National Cancer Institute has. But historically, I think it's 4%. Around 4% is what goes to pediatrics. It's about $200 million a year. And I always, the data point I share is like, I think that's what Starbucks revenue is in 3 days. So not a lot, because it's, in this country, there's almost 17,000 kids diagnosed every year. So the importance of, let me give you, because it's the 3 legs of the stool. You got government, you've got pharma, and I've kind of talked about those. And the third leg of the stool is foundations. And, I often talk about St. Jude, and they are wonderful. They've saved a lot of lives. I mean, they've been instrumental in a lot of progress. But as I explain to people, they have less than 100 beds. They aren't. I always joke, people often think of them as the Amazon of childhood cancer. Like if your child gets sick with cancer, you call St. Jude and it gets taken care of. And while again they're wonderful, they can't take care of everybody, and you have to fit into kind of a trial they're working on. So it's educating the public a little bit on that. You have American Cancer Society, who again, it's done a lot of wonderful stuff, but doesn't do a lot for kids historically. They're a very small percentage of what they raise goes to pediatrics. I wish it was commensurate with the marketing material they use. If you use 20% of your pictures for kids, put 20% of the money towards pediatrics. So foundations like ours, because when we started this, David, I didn't know what started it, because I wanted to honor my son, and I felt like I needed to do something after he died. To see the progress we've made because of an amazing group of board members, amazing group of doctors, where, when we put out a proposal, we're getting grant requests from all over the country, from very reputable places that we'd never, the importance for you as a researcher of foundations, not just like us. There's a lot of other reputable foundations, the National Pediatric Cancer Foundation, Alex's Lemonade Stand, Cure Search. There's a few that focus on the research side. Talk a little bit about the importance of foundations and their role in supporting the work that you guys do.
Yeah. So I think foundations like yours play an outsized role in supporting pediatric cancer research for a bunch of reasons. The one that's most obvious and most talked about is that 4% of NCI's budget is dedicated to pediatric cancer research and 96% for adult cancer research. But even competing for that 4% is really hard. So when we write a grant proposal to the National Cancer Institute, one of the criteria that are used to judge the worthiness of the proposal is the public health impact. So it's not hard to sell somebody on the public health impact of a new drug for breast cancer if 11% of adult women are going to develop breast cancer at some point in their life. It's a huge number of women, and therefore the public health impact of addressing that problem is really big. It's really hard to convince people that a drug that might be most useful for a disease that strikes 400 children a year is going to have a major health impact, or a major public health impact. So that's one challenge. The next challenge is that the proportion of grant applications to the National Cancer Institute that are actually funded is about 9%. So when I apply for money from the National Cancer Institute, I'm competing against people who are studying lung cancer and colon cancer and breast cancer. So I lose on public health impact. And there's no, with minor exceptions, there's no money that's set aside just for pediatric cancer. So I can just compete with other people who are in the pediatric cancer world. And I not only have to overcome the public health impact barrier, but I also have to be in the top 9% of all of the applications, which is, hard to do.
Yeah, no, absolutely.
And it's hard to do for somebody established like me. It's nearly impossible to do for somebody who's just starting out. So in order for there to be another generation of people who are willing to engage in pediatric cancer research, there needs to be a way for those people to get funding to pay for the research. And that's a huge place where foundations play a big role. A lot of the foundations that you mentioned are not just dedicated specifically for funding childhood cancer research, but have funding mechanisms specifically for young investigators who are just getting started, for example. And that first grant that pays for that first project can be among the hardest to get, because another thing that is a criteria for evaluating a grant application is your preliminary results. What have you accomplished so far? But if you're brand new in the field, there isn't going to be that much by definition, because you're brand new in the field.
Correct.
So you need to be able to generate that initial data that says my idea is a good one and I'm likely to succeed. And before you can be eligible for...
You almost have to show success before you get a chance to...
Yeah.
But it's a chicken or the egg. It's kind of... that's hard. And I think the other thing that I heard from you at one point in a prior conversation is the other challenge is with government grants is they tend to not to be more risk averse, not necessarily pursue where, what we try to do as a foundation is, it's high risk, high reward. It's not pursue, if you have a projected survival rate for a diagnosis of 30%, our goal isn't to get it from 30 to 35. Our goal is to take a shot at getting it from 30 to 80, making some material change in outcomes. And that my understanding is the NCI is much more conservative historically on how they fund.
Historically, they are. And it's rational if you think about it from a certain perspective. The NCI is taking taxpayer dollars and giving it to people like me and saying, go play in your lab. And therefore they want, at the end of my 5-year grant, they want to be able to show what they got for their money. And so if you fund projects that have a very high likelihood of success, obviously even very high likelihood isn't good, but you get more wins, and then that sort of justifies the next round of funding in the next federal budget. Whereas if you spend all of that money on things that have a small chance of success, even if the impact of that success would be very large, you don't get nearly as many wins. And then it becomes a lot harder to justify why you're spending all of that money.
And no politician wants to be behind. I mean, one of the projects we recently funded was through a veterinarian who's working on a bone cancer that is almost identical genetically in humans and dogs. I mean, no one wants to be grilled. Why are you giving money to? But there's promise there. The sample of using dogs are better. And for the record, this is really important. I'm going to look in the camera to say this: the dogs have the cancer is naturally occurring. This is not. They are not lab animals per se. It's dogs that are being treated for osteosarcoma. But that kind of stuff is I think no. People don't want to be grilled on why are you giving money to to a veterinarian to help kids
veterinarian
with cancer.
Yeah.
So it's one of the things that I've always appreciated about the group of doctors on, that willingness to make change. Because I do believe it, Sarah. And as we start to wrap up, there's a little bit of Don Quixote in me. As hard as it is to believe still when I say it, that the only treatment option Sebastian had was 40 years old. With the use of data, AI, the technology advances and our knowledge base. Because I think even in the last, 8 years that I've been in this world, the 7 years of the foundation, Sebastian was diagnosed in actually almost 9 years in 2015. One of the things that I've seen is progress in our knowledge, because, you've got to know more to know what you're going to attack. And some of the tools that are becoming available, particularly, like I said, with childhood cancer, the data sets are really small. So it's really hard, and it's really hard to study. It's hard to develop drugs because even in Sebastian's case, it's 300 to 400 cases of rhabdomyosarcoma. And then you learn that there's different types of rhabdomyosarcoma and they're each unique. It's really hard to get data. I mean, because you may have, I think at the time, Sloan Kettering they said they had more rhabdo cases than anyone else in the country. When we looked, I think it was like 20 cases a year. So it's not really enough to establish. Give me your thoughts on the future, like what you think about all these technologies and all these things that are coming to bear it and their impact on us accelerating improvements.
So I'm optimistic that with every technological advance that gets applied to childhood cancer, there's the opportunity for greater than incremental increases in what we understand. There are lots of challenges. AI works great with very large data sets, as you said. So if your data set is 300 kids a year, that's a lot less for a machine learning algorithm to work with than 110,000 cases of lung cancer a year.
Right.
And then there are issues related to what data points to look at, how to extract them from the medical record, how to extract them from a medical record in a way that preserves patient confidentiality. I think there's a lot of potential. I think that there's also a lot of barriers that we have to figure out how to overcome. I'm grateful that one of those barriers is that there aren't a huge number of kids that are diagnosed with these diseases every year, but that does limit the ability to use those sorts of technologies. Doesn't make it impossible. Just another,
No, there's no silver bullet.
Another
as
challenge.
we said earlier. There's no magic bullet in this. It's, but I'm grateful for individuals like you who've dedicated your lives to this, and hopeful that with some of these advancements, a greater understanding that before my time, we'll continue to see progress. But I want to thank you for your time, and I appreciate more than anything what you do out there in the front lines. It's a really hard job, and we need more resources and more support for you and your brethren. So thank you, David.
Well, thank you for inviting me down, and thank you for the support the foundation has given to our work over the years. And we're going to just continue to plug away at it until we win.
Thank you, David. Thank you all for listening. This was, again, hopefully gave you a different perspective on childhood cancer and a greater understanding. If you want to learn more, please check out our website at www.sebastianstrong.org. We've got an event coming up tomorrow night. I'm filming this on Friday, so April 27th, Howl at the Moon at the Tank. And then in 2 weeks, I'll be kayaking from Key Largo to Key West to raise money for pediatric cancer research. Yeah, it's 110 miles. It's a haul, but learn more about that on our website. Learn how you can support doctors like David and the important work they do. So thank you all so much. Thank you to Grant and Mike again for their hospitality, and Rachel for all she does behind the scenes.